Welcome to the Sleep to Dream Analytics Explainer video, where better sleep starts with better understanding. So today we're diving into the hidden world of a really common condition, sleep apnea, and what happens when it collides with something that seems totally routine, surgery. It turns out it's a balancing act where the stakes are incredibly high. Okay, let me start with a question for you. If you're someone whose own body literally obstructs your breathing every single night, what on earth could possibly be more dangerous than just falling asleep? The answer, believe it or not, is being put to sleep by an anesthesiologist. And we're going to break down exactly why that is by following a patient's entire journey, right from the beginning. So it all kicks off with the decision to even have surgery in the first place. For most people with what's called obstructive sleep apnea, or OSA, the go-to treatment is a CPAP machine. But what happens when that's just not working? Well, for these patients, surgery isn't the first choice. It's really the only one left. They might have actual physical blockages, or maybe the structure of their face is part of the problem. But honestly, a lot of the time, they just can't stand using a CPAP machine. It's bulky, it's uncomfortable, or sometimes a blocked nose just makes it impossible to use the mask. These are the folks who find themselves heading to the operating room. All right, so before any surgeon can get to work, the medical team needs a game plan. They have to see exactly what's going wrong in the airway when the patient is unconscious. And they have this really fascinating way of getting that sneak peek. It's called Drug Induced Sedation Endoscopy, or DISE for short. Think of it like a dress rehearsal for sleep. The anesthesiologist gives the patient just enough sedation to relax their airway muscles, and then a surgeon uses a teeny tiny camera to watch the collapse happen in real time. This isn't guesswork, they're getting a direct look at the problem. And this step-by-step process is what's so brilliant about it. The sedation mimics sleep, the surgeon sees exactly where the airway is collapsing. Is it the palate, the tongue, something else? And based on that direct visual, they can tailor the entire surgical plan specifically for that patient. It's an incredibly precise tool. Now we're getting to the absolute heart of the risk. You see, the state you're in during DISE and general anesthesia feels a lot like sleep, but there is one critical life or death difference. And here's the crux of it. In both natural sleep and under anesthesia, your airway muscles relax. But when you're sleeping normally, your brain has this built-in safety alarm. If you stop breathing, your body freaks out and forces you to arouse. That gasp or jolt that wakes you up so you can breathe again. Under anesthesia, that safety alarm is completely shut off, disabled. There is no automatic wake-up call. This quote from the source material just says it all perfectly. A person sleeping is naturally protected by their own body. An anesthetized patient is not. Their safety is 100% in the hands of the anesthesiologist because the drugs have silenced the body's most basic instinct to save itself. So, as you can imagine, this vulnerability creates a huge, huge challenge for the medical team. It's a situation they have a very specific name for. It's called a difficult airway. And for an anesthesiologist, that phrase is a really big deal. It means the two most fundamental ways of keeping a patient breathing, using a simple face mask or putting in a breathing tube, are going to be tricky or maybe even impossible. And guess what? Patients with sleep apnea are, by their very nature, the most likely candidates to have. Yeah, the patient's existing conditions just stack up as immediate risks during the surgery. The very same anatomy that causes their sleep apnea, like a small jaw, can make it physically tough to get a breathing tube in. If the patient is also morbidly obese, the weight on their chest can actually cause parts of their lungs to collapse under anesthesia. And any other health problems like heart disease get put under a ton of strain. But here's the kicker. The danger doesn't just vanish when the surgeon finishes. In a lot of ways, the riskiest part is just beginning. The patient basically has to run a gauntlet after the operation. So, right after surgery, the airway they just operated on is now swollen. It's at risk of bleeding, and it can get clogged up with secretions or even blood clots. So the great irony here is that the surgery meant to fix the airway obstruction can, for a short time, make it even worse. And at this point, you're probably asking a pretty logical question. Okay, the patient's going to be in pain, right? So why not just load them up with strong painkillers and make them comfortable? Well, this is the dilemma. Opioids are amazing for pain, no doubt, but for a sleep apnea patient, they have two really dangerous side effects. First, they reduce your natural drive to breathe. And second, they make it harder to arouse from sleep. They suppress that very same safety alarm we were just talking about. So using them becomes this dangerous balancing act between patient comfort and patient safety. And if all that wasn't enough to worry about, there's a delayed threat. A few days after surgery, after all that disrupted hospital sleep, the body tries to catch up on the deep, restorative REM sleep it's been missing. They call it a REM rebound. The problem? REM is the sleep stage where your muscles are the most relaxed and your airway is at its absolute most vulnerable. So just when it seems like things are getting better, the patient enters their riskiest time for natural sleep. So what all this means is that getting the patient safely out of the hospital isn't just a simple discharge process. It requires a really meticulous, step-by-step plan. A patient can't go home until they have passed every single item on a very strict checklist. They have to be completely awake with no more sedating drugs in their system. The swelling from the surgery has to be gone. And they've got to be able to use their CPAP machine if they need it, even if the whole point of the surgery was to hopefully get rid of it one day. Ultimately, successfully navigating this whole complex journey comes down to teamwork. The surgeon and the anesthesiologist have to be in perfect communication, from that very first DISE plan all the way to the final decision to send the patient home, with intense, careful monitoring every single step of the way. And that really makes you think, doesn't it? We've just peeled back all these layers of risk behind a single type of surgery for a super common condition. It just leaves you wondering, what other incredibly complex, high-stakes ballets are these medical teams performing every single day that we never even get to see? Thank you for watching the Sleep to Dream Analytics Explainer video. We hope you sleep well and dream easy.